Jenny, thank you very much, and thanks for the opportunity to be here. It's always splendid to follow Jim and Robert, inasmuch as actually I'm going to talk about a little more detail. Jim set the broad scene for where the research is going, and Robert has given us a wonderful view not only of what the world looks like, but what we can actually do about it. This particular presentation derives extensively from work that Martin Tobias has been doing, and I'll explain to you exactly what that work is in a moment. But here's the context. And I'm actually going to talk about some details not only about mortality, but morbidity as well. So this is disease occurrence, disease incidence and prevalence, as well as mortality from disease. Health loss in New Zealand is a way of capturing that information. And there was a report released on the Ministry's website in August this year, and it summarises what's going on here, our health loss and health expectancy, which I'll define for you in a moment, from the global burden of disease. And the global burden of disease is run out of the Institute of Health Metrics and Evaluation at the University of Washington in Seattle. Now, I'm actually an emeritus professor from the University of Washington, Seattle, but it's Martin Tobias who's done this work in association with that group and with Chris Murray's group more widely. But the global burden of disease collects data from, as you can see, 188 countries, and it works out health loss from more than 300 diseases and more than 60 risk factors, and comes up with a notion about health expectancy, both globally, regionally, as well as nationally. So, and there's a collaboration coming up, which we'll talk about very briefly in a minute. The burden of disease. Not just speaking about mortality, but, as I said, incidence and prevalence. It's a mature methodology for comparative monitoring of health losses, integrating both fatal and non-fatal outcomes, and it represents a major improvement over just thinking about mortality. It considers both health conditions and the risk factors for those conditions, and thus you can link to what goes on in the clinical arena and the public health arena as well, and it provides evidence to inform the way in which we might run health systems, strategic planning, priority setting, resource allocation, etc. And it's supplied part of the evidence for the recent refresh in the New Zealand Health Strategy, although I would be the first to admit that that is a wonderfully vague document. The Ministry of Health signed an MOU with the Institute of Health Metrics and Evaluation, and they're going to start with the Global Burden of Disease 2016. It's funded by the Gates Foundation, and all relevant New Zealand data are being used, and I'll talk about that in a moment, but it's going to be run in the future with two new countries, if you like, Māori New Zealand as well as non-Māori New Zealand, so we will get a better handle on just how that inequity looks, both in relation to disease burden and mortality. I'm going to just touch on these concepts for you. The details are less important than you get the point about years of life lost, and it's weighting each death according to the exact age at which the person died, based in comparison with a particular expectancy. And the non-fatal loss, years of, which is basically years of impaired health, if you like, and there's both an incidence perspective and a prevalence perspective. So this is based on new diseases, this is based on longer standing disease in the community. And the basic primary concept that drives this is the daily, which is a measure of the, so it's disease adjusted life years. So what you're looking at here is the loss of 1 year of healthy life, if you're talking about one daily, and it integrates both fatal losses and non-fatal losses. And this is an important way of thinking about the broader burden, because what you'll get is something that Robert hinted at very nicely, and that is that some of the non-fatal conditions contribute a lot to our disease burden as a country. So health expectancy, again, life expectancy, but here we're talking about disease-free life, if you like. It's the time the average person can expect to live in full health. Again, just a concept. It allows us to quantitate. And the important thing here is that it allows this comparison across diseases, both fatal and non-fatal, over time. And the basic question being asked here, are we adding life to years as well as years to life? These are the data sources from New Zealand, and I don't expect you to take in all of these, but there's a thing called the Health Tracker, which is a data linkage facility, and we'll hear more about that in later talks. We have a cancer registry. We have mortality collections. There's a minimum data set which comes from both public and private hospitals. There's the mental health data, there's a notifiable disease data, and there's a birth defects register. And then we have survey data based on both the health survey, the mental health survey, oral health, nutrition, alcohol and drug use, and tobacco use. And then there are some other sources which are relevant. Peer-reviewed research studies, obviously many of those. Published government and NGO and industry reports, the so-called grey literature, published reports and databases of WHO, OECD, etc. And then there are some other unpublished work that is available as well. Key findings. Important. So this is life expectancy, this is health expectancy at birth, basically. And in 1990, this was around 72.5, and it's now, most recent data, at 78.6. So there's about a 6-year increase in life expectancy over that period, something that Robert actually talked about also when he was talking about the world. Health expectancy, so years of full health, going from 63 up to 68. Notice that there's not as great a health gain as there is a life gain. So both life and health expectancy have increased, but we've actually got about a year less of full health for the folks who make it. And that's for men. And notice women, of course, live longer because men aren't as good at looking after their lives as women are. And it's an important distinction as well to note that they do better. We don't have data exactly of this sort for Māori, non-Māori, but we will have before too long. So this is what's happening to disability-adjusted life years. You'll see that it's actually an increasing health loss taken this way, but because the population is aging, and because we now have more older people, there's actually a somewhat decline associated with the age-adjusted, age-standardised. So the diseases are spread over an older population, if you like. Here's an important note. This is the so-called epidemiologic transition. And what that marked was the shift, which Robert already mentioned, the shift in a number of countries from a predominantly infectious diseases to predominantly chronic conditions, and I share his predilection for chronic disease as a descriptor because it describes some of the other things we're talking about. And indeed, some of the chronic conditions are actually communicable, so it's not entirely clear that that's the best thing to call them non-communicable diseases. Anyway, a decline over time, and New Zealand now has quite a low rate of infectious causes for death and disability. And indeed, as you can see from here, this is the infectious lot, this is injuries, and you can see that in 2013, the long-term conditions are accounting for approaching 90% of the health loss in New Zealand. These are indeed the conditions that most burden us in terms of individual experience that Robert talked about, and in terms of cost to the country. And here, to make the point about the fact that there are a wider group of diseases that are associated with morbidity rather than mortality, is the list of the most common and important ones. And right at the top is neuropsychiatric disorders. And this is referring, of course, to neurodegenerative diseases as well as psychiatric diseases. And these are slow killers. They are with us for a long time. Cancer is an extremely important burden. This is cardiovascular disease here, and then digestive diseases here. Musculoskeletal conditions, which Robert mentioned and which were discussed already, major importance. I have a knee replacement, which I thoroughly recommend for anyone who's struggling with knee problems. And again, personalising the things. So other non-communicable diseases, and then chronic liver, lung and kidney disease, here, injuries, and then maternal, neonatal, nutritional and infectious diseases. As you can see, modest contributions, not unimportant, but modest. And neurologic and psychiatric, cardiovascular, digestive, musculoskeletal diseases and cancer account for almost 2/3 of the health loss that we see in New Zealand. Health loss, in the same way that we saw the age-adjusted, the age-standardised rates coming down for the dailies as a whole, you'll see that most of these are coming down also with the primary and important exception of neuropsychiatric disorders, which are actually going up as a burden, part of the burden of our disease. And you can see where they are. They're in that position that I just showed you in the previous slide. There are some important differences between men and women. I would like to be able to put up in this format the Māori, non-Māori differences, but let me at least put the men-women differences. An important one to note is the pattern of neuropsychiatric disorders differs between men and women. So in men here, something odd happened here. Somebody's twitched these. But the important thing is here, depressive disorders. What on earth happened here? This is not how this should look. Okay. I hate shifting from Macs to Windows. But the primary thing is that women particularly suffer more from depressive and anxiety disorders, and men more from drug addiction and suicide. And there are important implications for the way in which we handle those disease burdens in the community. Notice that as you go from young to older people here, the pattern of health loss causes, so this is the primary, secondary, third, fourth, fifth, top 5 here, accounting for somewhere between 30 and 50% of all health losses at various ages. And you'll see, of course, that in children, birth defects are an important contribution, followed by neonatal disorders, iron deficiency, asthma, and sudden unexpected death. And then as you get into youth, you end up with back disorders and self-harm and injury. Addiction is important, as are depressive disorders. Among young adults, you're beginning to see, notice the back disorders are really important, just as Robert mentioned earlier on. And then the continuing presence of neuropsychiatric disorders in here. And then it's when you get to the middle age group, you begin to see coronary heart disease, lung cancer, chronic obstructive pulmonary disease. Depressive disorders are still with us. And then the contributions to dementia. And if you split this further, you end up with dementia becoming an extremely important part of the health loss and health burden. This is what's been happening to various diseases. Robert mentioned coronary heart disease falling. Diabetes gone up considerably. Notice it seems to have plateaued as a disease burden, not as a prevalence. We'll talk a little bit about that in a minute. Bowel cancer is coming down somewhat. We're just introducing a screening program, and we might expect bowel cancer ought to be utterly preventable in the same way. We know more about the causes of bowel cancer than just about any other cancers, and we have good ways of detecting it early. We should do better. This has been my research area for a long time. We should do way better with this. Sudden unexpected death in infants has been coming down considerably, although it looks like it's flattened at some level. Transport injuries, and then self-harm, which is down a little as a burden, but still a huge problem, as we just saw in the previous slide. And then you can look at what the risk factors are for these diseases collectively. And I'm not going to go through in detail with each one. You can see the way this will be, and you can look at these slides later on. But notice diet, obesity, tobacco use, high systolic blood pressure, this is glucose, this is cholesterol. So we're seeing all the things that we might expect to see. And these, as we've already heard, are almost all amenable to improvement. And this is the sort of, nonetheless, we're seeing some declines as their contribution to the burden of disease. Again, not least because of the way in which cardiovascular disease has been falling. Notice that because of the rising obesity in the community, that now we have more health loss attributable to obesity than we do to tobacco in New Zealand, whether you look at it in just simply disability adjusted life years, or we look at it here in the age-adjusted look at this. Either way, this is not to say we're doing as well with tobacco as we should be, although we're doing it. It does suggest we have a growing problem, so to speak, with obesity. Obesity is actually you switched these again. So basically, obesity prevalence is continuing, but the burden is actually fairly flat because there is some degree of management, if you like, about how these things are happening. Summary. Health is improving. It doesn't imply reduction in health expenditure. And you saw that although the life expectancy has improved, health expectancy has not improved as much. At the same time, indeed, morbidity is expanding. There are more disabling, non-fatal conditions. This is a key element. You know, you've had three old guys standing up here telling you that the health of the elderly is really important, not surprisingly. We're transitioning the health system for multimorbidity. There are people out there living with multiple diseases, and we need to think more about how that should be managed. Mental health, addiction, dementia are particular challenges for us, and they will be increasing challenges for everybody. Musculoskeletal disorders also increasing. Cardiovascular disorders and diabetes represent an unfinished agenda. I think that's a polite way of saying that we're still, these are genuinely coming down, but we have a problem with diabetes. And Robert talked about some of the possible solutions that we can think about there. Health loss, nonetheless, is becoming decoupled from prevalence. We are living with people who are surviving better with their obesity and their diabetes. They are being better managed, but they're not going away. Greatly improving prevention, again, something we've heard already. So, are we doing enough? What are we doing? There's a whole series of things that New Zealand's acting on in relation to risk factors. Robert mentioned 169 indicators. I love it. But we do have things to think about, both risk factors and long-term conditions. Is it enough? Are we doing this properly? And I suspect that's a proper part of this conversation that we should be having. Just 2 seconds on the Global Burden of Diseases program. They're going to be adding new diseases and new risk factors so that we'll have a better capacity to manage, to image the world's disease burden. We are going to have subnational analyses, particularly for New Zealand, Māori, non-Māori. And that's an important thing. And then I already mentioned that the ministry has signed an MOU so that we will have regular input from the Institute of Health Metrics and Evaluation into the way in which diseases are monitored in New Zealand. If you want to look beyond the health loss report, which you can get online, there are web-based tools that people could be interested. I put this up because Martin suggested we should read EPIC Measures, available as a book from the Ministry of Health, or as hard copy, or you can wait for the movie. And many thanks to Chris Murray, who heads up the Institute of Health Metrics and Evaluation. And I thank you very much for your attention.